Know that it has been a long day, but we are going to switch to a completely different topic, which is that of cardiosynchro. We have two live cases in two rooms. If I understand correctly, we are going to have one room working with a St. Jude device, and the other one will be using a Medtronic device. So we are going to see the two cases. I was asked to start with a talk to review the multi-point pacing technology. I will talk about that technology, but in the context of how to prevent non-responders, and I'd like to talk also in more general terms and tell or discuss how this technology can help with that. I will speak for 30 minutes and then we will go to the two labs and we will finish with a discussion, a talk by Dr. Medina on MRI. For those of you who do not know me, my name is Vidal. I come from McGill University in Canada. I did my training with Dr. Josephson in Boston. So these are my disclosures. The response to cardiosynchro is a problem, and we are always trying to see how we can improve response to this therapy, which is a very important therapy that can be life-saving and reduce heart failure, but something that doesn't benefit everybody maximally. A very important part is how can we define what is response and what is non-response. And we're also going to discuss how multi-point pacing may help with the response to cardiosynchro. Some patients have the ideal result. These are the super responders, and that is defined by different types of studies, but in general, what it may happen in 1/3 of the patients who receive this therapy. In general, these are patients with left branch block, usually with a smaller left atrial volume, patients with heart failure of shorter duration, and also a longer QRS. The longer the QRS, the better the probability to respond well. Now, why is this important? Because the patients who are good responders have a much better prognosis. The under-responders have a probability of death and heart failure, which are much higher than the super-responders. The challenge is that almost 30 to 40% of patients don't respond to therapy. There are many factors that can explain this, and an important one is how to program the device. You can be an excellent electrophysiologist and surgeon and come in to place the wires in the ideal position. But if later you don't program the device properly and optimally, you will not obtain the maximal response to this therapy, and that is a shame. Other things are arrhythmias, anemia, if the position is not ideal, if there is no percentage of biventricular pacing that is high, etc. So I usually divide into 4 how we can reduce the number of non-responders. Of course, the most important thing is patient selection to start with. If you select a patient who doesn't meet the criteria to be a responder, you can do whatever you want, but the response will not be the same. The other has to do with the techniques during surgery. Use venography to see all the options and do a good quality venography is of great help in deciding the options to place the wire. Also measuring conduction times, avoiding phrenic stimulation because that may limit your pacing options later on. The use of quadripolar leads. Post-implant, how to program the device, when to decide not to pace, new technologies, including the MPP and others that I will be discussing, and long-term follow-up. So the patient, we need to remember that cardiac resynchro solves the problem of the left branch. The idea of placing a lead in the left ventricle corrects the left branch block to resynchronize the heart. It's not surprising that the patients who are will more probably respond are the ones who have the typical left branch block. The RAF study, which was a Canadian study that showed a reduction in mortality when they added the cardioresynchro to the defibrillator, showed very clearly in sub-analyses that the patients who had the higher benefit were the patients with QRS of more than 150 milliseconds, patients with left branch block, and you can see that the others didn't have any benefit, and patients in sinus rhythm. The MADIT CRT, which was the American study, at the beginning didn't show a mortality benefit, but then the long-term study that was published later on showed that in patients only with left branch block had a mortality benefit, whereas those that didn't have a left branch block didn't show that benefit or didn't receive the benefit. In the MADIT CRT, they combined a response score using those factors, the same that are always shown, female sex, non-ischemic disease, etc., etc., and other response, or the more the higher the points, the greater the probability of benefit in terms of mortality. The left branch block in all those studies wasn't very strictly defined, but when we see what is in fact a left branch block, there is a definition by Strauss, which is even more specific and requires a QRS duration of more than 140 milliseconds in men, and 130 in women, a QSRS in leads V1 and V2, and this, which is very important, notching in at least 2 leads in the EKG. These are 2 examples. Here we can see the left branch block, the true one, with the notching with the broad QRS, whereas in this one you don't see that type of notching. And if you see patients with heart failure with long-term EKGs, there are some patients who have an EKG with a QRS of 115, next year 120, then the next year 125, and progressively the amplitude of the QRS increases, which gives you a pattern of left branch block, but it is not a block. It's progressive dilatation with reduced conduction times, and this is not the ideal patient to respond to CRT. The patient who has that notching is a patient who has a block, a true block in the left branch, and when the lead is placed on the left wall, you can actually address this anomaly. The operative technique. This is a study that shows the reasons for not being able to place the left lead, and with time and with experience and with the advances in technology. In the first few cases, the most important problem was the inability to access the coronary sinus, and the problem of not having an adequate branch. That was less common. And in more recent cases, accessing the coronary sinus is no longer the problem, and more frequently we see problems with having access to an adequate branch. And this may be due to the fact that we are increasingly becoming more stringent in the selection and of the branch, and if there is no adequate branch, we don't leave a lead in a branch that offers no probability of response. The quadripolar technique has completely changed the CRT procedure, because with 4 electrodes we have many options of pacing. We can avoid apical pacing, and we can avoid phrenic stimulation, which is a problem that limits the application of CRT. A study comparing the two types of leads, quadripolar and bipolar, showed that with the quadripolar there is much less probability of having ventricular lead associated events or phrenic stimulation, etc. Another American observational study with more than 20,000 patients suggests that the use of the quadripolar lead is associated with a reduced mortality. It is not randomized, so it cannot be said that it is just because of the quadripolar lead. Maybe there is more experience also, and the technique has improved as well. But with the larger array of options, you can increase the response to therapy, and I think that it does have an important impact on mortality. This is a study that shows the ideal positioning or placement for the leads. If you place it in the anterior vein, it is not ideal because you're pacing very close to the right ventricle. In the posterior vein, not. You need to go lateral, anterolateral, or posterolateral, and avoid the apex. When the right ventricular lead is positioned at the right apex, and if the left one is also at the apex, you're pacing the two apices, and this is useless. There needs to be a distance between the two leads in order to achieve a response with a biventricular pacing. There are different algorithms to measure during the procedure in order to have an idea of the electrical distance and the response that you can have during the procedure. That is a way to see it, which is called the QLV. That is the distance between the start of the QRS and the local electrogram of the left ventricle where you place the lead. In this case, you can see that it is 90 milliseconds. In this case, it's much longer. It's 165 milliseconds. The QLV is obviously, when it is longer, the better the response. Here they divide between greater and lesser than 125 milliseconds, and when it is more than 95, it is better in all the indices, ejection fraction, etc., etc. This is seen here in the groups. The response to therapy continues to improve as the distances grow larger, because it means that you are at a point in the ventricle where the activation occurs later. This is another way to calculate it. It uses the same QLV, but it gives a ratio between the QLV and the QRS, because a QLV of 90 milliseconds when the QRS is 130 is not the same, is not equal to 90 seconds when you have a left branch block with a QRS at 200. So that measurement considers the QLV and the size of the QRS, and it divides it by more or less 50% of the measure of the QRS, and that is associated also with the response to therapy. So these are tricks that you can use during the procedure with a well-done venogram to consider the options. You can go in with one first option. If the QLV is not good, you can take time to see if there is a better vein and then make your selection. The other is with a quadripolar lead, where you can measure distances between the different electrodes to confirm whether the 1, 2, 3, and 4 is the best position for pacing if there are no problems with the phrenic nerve or with very high thresholds. Postoperatively, there are many things that have been studied and very few things that are related with a response. The placement of the lead, the only thing that was proven is that you need to avoid the apical positioning. And my personal opinion is that this is especially important when the right ventricular lead is apical. And in most cases of synchrodefibrillators, the lead is more apical in order to have the adequate vector. The CRT5 pacemakers, we are used to placing the right ventricular lead more basally because there is no issue of where the lead is for defibrillation. You can place the right ventricular lead in the outflow tract or more basal, and the relative position of the left cardio considers where you place the right lead also. The time, AV time, and all the technologies to correct it and measure it have not shown any benefit. There are different algorithms from many companies that have conducted randomized studies, and this has not shown any benefit. My opinion about this is that if you're going to measure the AV delay by measuring the P wave and the remplissage time of the ventricle without considering the ventricular contraction and the conduction time, the AV conduction time, you actually lose how to pace the ventricles. You need to synchronize the ventricles, and if you do it with an AV time that is good, a shorter, that is good, but sometimes you program a longer one, AV time, to allow for time between the atrium and the ventricle, but then you lose cardiac resync because what you have is a pseudo-fusion in the ventricle and you really don't manage to resynchronize the ventricle. And you also miss the opportunity of pacing with the intrinsic conduction and fusion, which is something that we will show later. The VV delay, we'll mention it later on. Now, which are the new algorithms that can be used to improve cardiac resync? One is MPP, multipoint pacing. The other one is a type of fusion with ventricular pacing and native conduction of the heart in a patient who doesn't have a complete block or who does not have a extremely long conduction time. The adaptive LV is by pacing only the left ventricle, but there is also another type of fusion, which is yes, a fusion, but with the pacing of both ventricles. Multipoint pacing. The idea is to be able to pace from two electrodes. Since we have quadripolar electrodes, the ability to pace from 2 points at the same time. Than the left ventricular lead. And now, which is the concept? The concept is if you pace from 1 point, there is propagation in this way. It's progressive propagation towards the rest of the ventricle. But if you pace from more than 1 point, the conduction and the way you achieve propagation may be more uniform. And you can actually depolarize a larger portion of the ventricle much faster and have a finer QRS by pacing in 2 points instead of 1. This is the St. Jude device. There are 10 options for pacing with a quadripolar electrode, and if it is a pacemaker, you have 4 more vectors using the device for pacing. To program the multipoint, you can choose to start on the left or on the right. If you start on the left, you need to decide and select 2 electrodes, 2 vectors, 2 left vectors, and you need to program a time between the first and the second one, and that time may vary between 5 and 80 milliseconds, and as we will see, the best thing is to use 5 milliseconds. The second time you need at least 5 milliseconds, and that can be programmed as you wish. Now, if you start with the right, it's the same. There are some studies of acute effects and other long-term effects, studies to determine the effect of the multipoint pacing from the electrical point of view with 3D mapping, showing here that when you use multipoint pacing, the activation occurs faster and it's more uniform for the ventricle. Now, from the mechanical standpoint and comparing multipoint pacing with conventional pacing, there is an improvement in the ejection fraction and reduction of desynchrony when you compare multipoint with a conventional pacing. From the hemodynamic point of view, also comparing multipoint, the optimal configuration of multipoint, comparing it with the conventional pacing, in 3/4 of the patients you can achieve superior hemodynamic acute response using the multipoint pacing. Now, this is a study on first-year response, 44 patients, and it shows the rate of responders and non-responders, responders in green, non-responders in gray. And you can see that with multipoint there are less non-responders than with the conventional pacing. This is another one, and this classifies in terms of super responders, responders, non-responders, and negative responders. And you can also see the same thing with multipoint pacing. The proportion of patients who respond better is increased. It increases out to 12 months. This is another study from Italy showing more or less the same thing. This has a follow-up of 6 months, and the percentage of patients who improved with multipoint was great. With multipoint on was greater than with multipoint off. An important point is this one here. We obviously need to use 2 electrodes, and not all electrodes can be used because of limitations of high thresholds or phrenic stimulation. They reported that in 88% of the patients, they could program 2 vectors without phrenic stimulation with a 3-volt threshold or less. Increasing the threshold to 5, you could have almost all people with 2 electrodes pacing. This is perhaps the largest study with 500 patients. The ID study, it's an American study, which was a study to compare or to determine the efficacy and safety of this technology. They took 500 patients and they implanted them with a device with a multipoint technology. They conducted an acute test to determine whether with the MPP they could have a better response than with the conventional pacing. If not, They were put into a registry. Those who benefited were randomized to program with multipoint or without multipoint. The primary endpoint was a non-inferiority uh, design comparing with the biventricular, and they demonstrated that the multipoint was non-inferior to the conventional one, and that was the primary endpoint. And what they found in the sub-analysis, which I think is the most important thing, because in the study they allowed to program the electrodes as the people wished, and they divided the patients in 3 subgroups. This was later, but they compared patients in whom the distance between the 2 vectors selected was in lower than 30 millimeters. That is, taking 2 that were close. The other one, where the distance was at least 30 millimeters, but where the time between the first stimulation and the second one was more than 5 milliseconds. And the third group, when they had at least 30 millimeters and only 5 milliseconds between the first and the second pacing. These are the leads available, and I think that the study was done only with this lead. And you can see the distance between 1 and 2 is 20, between 1 and 3 is 30, and this is 47. It means then that in this group, everybody has to have pacing with 1, 2, 3 or 1, 2, 4. And what was the difference in response? In subgroup 3, the response was much better than in the other subgroups. That is to say that if you are going to do multipoint pacing, it needs to be almost simultaneous. The pacing has to be almost simultaneous, and you need to program with only 5 milliseconds difference in order to make sure that the pacing occurs uniformly. If you use a larger distance between the first and the second one, then you lose the entire concept of simultaneous pacing. And a distance of at least 2 electrodes, 1, 2, 3, 2, 2, 4, in order to have more adequate pacing. We are in the process of conducting another study. We are also participating in this study in Canada. It's on MPP. It's a randomized study in patients who are non-responders. And 6-month follow-up, randomizing using the MPP on or off to see if long-term there is a benefit with this technology. And this is something that we are waiting for, the results of this study. Another technology which is available from Medtronic is the adaptive LV pacing. This technology tries to be a different strategy. If the patient has normal conduction through the right branch, why pace with the right ventricle? It's a bit meaningless to have an adequate conduction pathway and having to pace in the right ventricle. If the problem is a pure left branch block, why not pace only in the left side? The problem is that with the older devices, there was no way to know when to pace in order to get the fusion and to have biventricular pacing. You had to have a very short AV time to ensure that there was a biventricular pacing, and that way you pay the price of having a very short AV time, and that affects the remplissage time. So in patients with normal conduction times, if you have to do biventricular pacing with a very short DLV, you can lose the clearing time of the ventricle and also pacing the right side without having to do it really. How does it work? The device measures the AV time, and it tries to pace the left ventricle 70% of the AV time, or at least for 40 milliseconds before the intrinsic sensing. The algorithm is this one. If there is sinus rhythm, if the conduction time is normal, and normal in this case is a sense V-send of 200 milliseconds or less. If the patient is paced in the atrium, it may be up to 250 milliseconds. If it's less than 200 and the heart rate under 100, it's going to pace only the left side. If the conduction time is longer than 200 milliseconds, then it will go to biventricular pacing in an attempt at achieving fusion with the QRS with an intrinsic AV delay of at least 50 milliseconds shorter than the conduction in time. We are participating in another clinical trial called the AdaptResponse, looking at the long-term effect of this algorithm. Everybody who has a left bundle branch block that is typical with the Strauss criteria with a PR under 200 milliseconds, this is randomized to a biventricular or to the adaptive LV.
En 15 minutos pasamos. Ok, sí, en 15 minutos. El otro algoritmo interesante del...
Another interesting algorithm of fusion pacing is the one that St. Jude is recently launching, which is the CRT, SYNCAF CRT. And the idea is that by having the quadripolar from where you can do the MPP, you may also determine when to pace the DLV. So this slide is explanatory how it works. It measures time. Every 256 cycles, it takes a measurement of the conduction time. And then, if it's 180 milliseconds, it will drop from 50 milliseconds the program AV and will pace at 134, so that the biventricular pacing is done with the intention to fuse with the intrinsic conduction of the intrinsic conduction. If the patient is in total block, obviously this doesn't work and it starts pacing formal ventricular. This is a trial which was presented in the HOS, is not yet published. This is called the negative hysteresis of less than 50 biventricular, and it reduces the QRS. This is the conventional 142 milliseconds with the negative hysteresis to fuse in these patients to less than 50, drops to 130. And if you can program the negative hysteresis and check minus 50, minus 60, minus 30, and choose the best, you may further improve up to 123. Now, which are the differences? Well, both are different ways to do the fusion pacing. The adaptive CRT is done on a minute-by-minute basis. The other is done every 256 cycles. The fusion pacing is this. St. Jude doesn't do it because it only has BV pacing and not LV only. To do it, you will have to program the output of the right ventricle very low. But probably you have to do that very carefully to ensure that the patient has no risk of block. The bi-diffusion pacing, Medtronic can do it as well. And the time of negative hysteresis in the Adapt Medtronic, it is done automatically by the machine. In St. Jude, you have the possibility to adjust the negative hysteresis according to the EKG. This is a poster presented by Dr. Rodano from Australia at the Asian Pacific Heart Rate Society, and he compared all the options of conventional BV, conventional MPP, negative hysteresis. I think I lost the mic. It's back. And to summarize, the negative hysteresis with MPP decreased the QRS to the largest extent of all options. Follow-up is extremely important. This is from our Canadian guidelines saying that in each follow-up, you must be optimizing the medications with the device. With atrial stimulation, you can increase the beta blocker according to the blood pressure that may rise, and we can adjust all the medicines. So this is very important. You must assess the response, and if there is not a good response, you must find out why. If the percentage is not more than 95%, you must determine why. If it's because there are too many extrasystole, you can do ablation of extrasystoles. Tomorrow we will have several cases of PVC ablation. This is exactly what you can do in this type of patients. If there is atrial fibrillation, you must treat the atrial fibrillation. If the patient has sinus tachycardia, which passes the upper tract limit, you must administer beta blocker or increase the upper tract. If there is no response because the leads are poorly paced or because there is phrenic stimulation or pacing, you must consider the possibility of changing the device or revising the lead. When you change the generator, when you do any type of procedure in the pocket, you must assess the patient at length. Do we need CRT? Do we have response, yes or no? Do you have to change anything? Do you have to change the pacemaker? Can we do a downgrade to CRTP? Maybe that would be the ideal if the patient is not ischemic and had a very good response, but the ejection fraction is now 60%. I replaced the CRTD for a CRTP, and that's not a downgrade, but an upgrade. The patient no longer has the label. Well, it has a device with less components that may have recalls and advisories and problems. The only thing you must take into account is that the initial device must be placed with a DF1 lead, because the DF4 is so difficult that you can't place a CRTP because there is no connection to place it. So I am one of the only ones that from the very beginning, in particular with CRTD, use the F1 to reserve the option of having a possibility to change it for a CRTP. So in conclusion, patient selection is basic in situations with limited resources. Choosing patients with higher probabilities to respond and the patient with a real left branch block. I encourage you to use the Strauss criteria. These are the patients that are more likely to respond. Venogram is very important. The quadripolar lead is the standard of care to use in every patient. You have to measure the CRT percentage and be careful with the percentages that the device measures, because sometimes there are fusions and it's worthwhile to do a Holter, a stress test to make sure that the response is adequate. Do ECGs often to determine the RQS. Algorithms may help to improve the response, either by improving fusion or in cases of non-responders when there is no other option. MPP can be a tool that helps. You must keep in mind that it uses the more battery, so you have to be very selective with your patients. And to continue to reassess the patient. Are there any questions about this topic before we go to the various rooms?